Welcome to Straight Outta Health IT. Getting into health tech is rough, but here's an unfiltered dialogue of healthcare leaders and influencers covering a wide variety of issues affecting healthcare and the health tech industry. And now your host, Christopher Cunny.
Hello, this is Christopher Cunny, and welcome back to another edition of Straight Out of Health IT. Today, we're recording this episode in Nashville, Tennessee, as we participate in the ViVe 2023 conference. So for those of you who may not know what ViVe is a go-to event for information technology, healthcare professionals, a next-level experience that brings C-suite, senior digital health leaders and buyers, healthcare startups, investors, government, and solution providers together to advance healthcare. And during this episode of Straight Outta Health IT, we're going to chat a little bit about rural health and the impact of the current economic conditions on rural healthcare. And with me today is an amazing individual that is one of the foremost experts in this space. And I'd like to introduce Dr. Michael Hasselberg. He is the Associate Professor of Psychiatry, Clinical Nursing, and Digital Science at the University of Rochester. He also serves as the first Chief Digital Officer for the University of Rochester Medicine and is the co-director of the University of Rochester Health Lab, the Health Systems Digital Health Incubator. Dr. Hasselberg was recently named to the top 50 in digital health list by Rock Health to recognize his work to improve health equity through technology innovation during the COVID-19 pandemic. He's a board-certified psychiatric medical health nurse practitioner. Dr. Hasselberg completed his PhD in health practice research at the University of Rochester and a postdoctorate certificate in health leadership at Johnson School of Management at Cornell University. His expertise spans health and technology as a Robert Wood Johnson Foundation Clinical Scholar Fellow and advisor on digital health modalities to the New York State Department of Health, the Department of Health and Human Services, and the National Quality Forum. He also serves as an independent consultant to several digital health startup companies, private foundations, and health systems across the country. He has a passion for rural health and focuses much of his attention on advocating for the advancement of technology, expanding services and policies to address health needs in these underserved communities. So welcome to Straight Outta Health IT, Dr. Hasselberg.
Oh, thank you so much, Christopher. I'm stoked to be here and excited to talk with you today.
Excited to have you on the program. You know, one of the things I ask my guests to share with our audience is that obviously you have a very impressive resume and have been recognized for your efforts as a leader in this space. But that's part of the story. So I'd like you maybe to spend a minute just talking about your own personal journey, what got you into the field of psychiatry, and how did you end up moving from that into now technology and leading digital transformation and innovation in this space?
I can't wait to tell you about my story.
Wonderful.
I come from a family of engineers. My father was an engineer at Eastman Kodak Company and kind of led some of the innovation work on the digital front at Kodak. And, I was always drawn to technology and the innovation work that my dad was doing. But I actually went a different direction.
Yeah, I was completely different.
I was the first in my family to go into healthcare. And the idea of serving others really excited me, and I was attracted to it. How I fell into psychiatry was in some ways kind of serendipity. As I was in nursing school, the health system in Rochester supported my nursing degree, but in exchange, I needed to work as a nurse's aide during my evenings and weekends and holidays.
Exactly.
And they put me where they had the greatest need, and the greatest need was on an inpatient geriatric psychiatry unit. And when I worked on that unit, I fell in love with behavioral health. I fell in love with the geriatric population and kind of said,
here's my mission, here's my passion.
And that's where I was going to,
Wonderful.
Went back to school, became a psychiatric nurse practitioner, and started my journey as a psych MP in rural area in upstate New York.
Sure.
And that area, I was the only psychiatric prescriber for 6 counties.
Oh, my goodness.
So, I served the jail, I served the nursing homes, I did the outpatient psychopharm clinic, and I became really passionate about kind of health disparities in these rural communities. And I was really struck by how these communities, despite those disparities, really kind of came together. Everyone knew each other, everyone supported each other. And,
Sure.
I liked that ethos. Ended up coming back to Rochester, finished a doctorate degree. And when I finished my PhD, I ended up taking a faculty position at the university. And how I actually came back to where I started with my interest in technology with my father was the chair of the Department of Psychiatry said, hey, I want you to join faculty in my department, but I want you to develop telemedicine for us. And
that's interesting. So telepsychiatry.
Yeah, 10 plus years ago, before telemedicine was cool.
I was going to say, that's really innovative.
Before there was reimbursement for it. And I knew nothing about telemedicine, but I was like, I need a faculty appointment.
Right.
Sure, I'm your guy.
Exactly.
I'll do this. But I knew that I wanted to address those gaps in those rural communities. And I saw technology and telemedicine as a medium to do that.
Sure.
Ended up getting lots of grant money and ended up building a very large telemedicine infrastructure across the entire state of New York. Ended up going back to school to understand the business of healthcare because I needed to figure out how to pay for this.
How to monetize this.
Well, how can I pay for my psychiatrist and psych MPs to keep them whole and not have to worry about chasing the next grant to do that?
Exactly.
So the timing was right. In the country, the ACA just started to be rolled out. People were starting to talk about the move from volume to value. I needed to understand that. I was able to bring that knowledge back to start negotiating with the commercial insurers in our market and even the state Medicaid plan around early kind of risk-based quality arrangements to support those telemedicine models. I then reached a point, however, Christopher, where I couldn't grow those models any further because I couldn't graduate psychiatrists fast enough to take on more patients. Figured out reimbursement, figured out the regs. Got involved with innovation, started getting into technologies like mobile apps and working with the engineering school to develop technology solutions that didn't need to have a provider on the other end to deliver care. And moved
you were really in the forefront.
Moved from mobile apps into VR applications, started to dabble in machine learning about 5 years ago, even before it really had
the chat GPT.
A clear use case in healthcare. And then COVID happened, right? And every health system in the country had to move to telehealth overnight. I was tapped on the shoulder to kind of stand up telehealth for the health system with other partners. 6 months in, we realized, listen, this isn't going away. COVID is here to stay, at least for a while. We have to digitalize everything we're doing in the health system, and we didn't have a way to prioritize. Everyone was raising their hands saying, I need digital health over here. We're like, sure, we'll help you. But we just stretched all of our resources thin. And so then I was asked to take my current position of this new position for my health system of Chief Digital Health Officer to kind of organize what that strategy looked like. And so
reimagine what the delivery of care now truly looks like.
Exactly.
Absolutely.
And so, it's been a fun ride, and it's looped me back to my childhood with my dad in engineering, then, my passion of serving others and again, addressing disparities in rural health. So it's, love it.
Well, what a great story. And thank you for sharing how this has all brought you to where you are today. And I wanted to go back and circle and drill down a little bit more on health disparities within the rural community. In rural areas, health facilities may be few and far between, making it difficult for residents to receive timely care. There's transportation barriers, lack of health insurance, limited availability to healthcare professionals that can really further exacerbate that divide. As a result, people living in rural areas are more likely to result more significant challenges with chronic illnesses, experiencing preventable hospitalization, and lowering their life expectancy compared to other urban counterparts. So share with us a little bit your perspective, or can describe for us how you define what the true health equity gaps are and how they impact, these rural communities.
Yeah. So little bit about Rochester and the University of Rochester. We're a mid-sized health system that serves a large geography. And so right from the urban inner city of Rochester, which looks like any mid-sized city around the country, and of course there are disparities there, but you go 25 miles outside of the city limits,
to different
and
world.
it is very rural. A lot of farmland, not a lot of resources there. And what we had found during COVID for these communities, when everybody was kind of forced to digital modalities and we were trying to keep people out of our hospital walls and keep them in their homes, we found actually that these rural communities, and specifically the Medicaid population, did really, really well with telehealth in particular. But there was a caveat to what we found in our Medicaid data. It was in the rural communities that, yes, they were engaging in telehealth modalities, and yes, they had better outcomes at lower cost, but they were only engaging in audio only. They weren't engaging in video. And so we wanted to understand that, and we wanted to understand, is it because there's no broadband access out in these rural communities? And that actually wasn't the case in New York. We've invested a lot of money into the broadband infrastructure. What we had found was there was significant poverty out in those zip codes, poverty higher than the poverty in our inner city. And patients couldn't afford internet access in their home. And the only internet access that they had available to them were the data plans on their cellular plans. And we know video is very data intensive, and folks didn't want to use their data plans for video. And so that's been probably the biggest barrier in our rural communities, even with technology, is the poverty. And then with poverty, we've got transportation issues. We've got our specialists up in the urban areas, you know, they're not attracted to going down and living in a rural community and setting up shop. And even our generalists, our primary care providers, aren't looking to set up shop in these rural communities. So really the number one driver around us is poverty. And then so we're trying to kind of think of creative ways of overcoming that barrier to get care out there.
No, that's great. And let's drill down a little further into that as well. Now, how is technology, understanding those disparities or those social determinants of health that are impacting folks in those rural communities, lack of broadband or lack of resources, funding to provide, to be able to deliver high caliber virtual care? Talk to me about how you're solving that equation. What are some of the technologies or what are some of the things you're doing to start to close that health equity gap?
Couple of areas. So we know that over 90% of our population have smartphones. And again, there are things that, you know, with the data plans on the smartphones, unlimited text, unlimited call, hence why we saw a lot of those audio only visits. So we're looking at technologies in the SMS texting space, where we can engage patients with like chatbot like interactions. Mobile apps, you know, a lot of opportunities there. You can download the mobile app, it sits on your phone. Once it's downloaded, not eating up data, you can interact. And then when you hit Wi-Fi hotspots, the data can feed back up to the health system. So opportunities there. Now, on the video telehealth side, you know, we're thinking creatively of where are there locations in these communities that are part of the patient's everyday journey already, that are broadband enabled. And so some of the things that I like to keep an eye on, that I'm excited about, the idea of Dollar General, you know, moving into healthcare and, you know, announcing in 2021, they hired Dr. Albert Wu as their CMO. What a great potential opportunity. There's a Dollar General like every 3 miles in these communities. And what an opportunity to potentially create that as an access point. You know, you think of the CVS Healths of the world, the Walgreens Village MDs, and you think about Walmart Health, you know, really kind of great opportunities. But even beyond kind of retailers, you think about, what about delivering healthcare into libraries or community centers or barber shops? And so it's really kind of
meeting the patient where they are.
Exactly. Innovating around the site of care. The site of care per se doesn't need to be within clinic walls, but at the same time, everyone's trying to move to care at the home, but that may not be feasible in some of these rural communities. So what are the other sites that we can innovate around? And so that excites me.
That's great. And I really like your strategy around meeting the patient where they are, where they're most comfortable being as well too. And so those places that they currently do business, whether it's Dollar General or in the local barbershop, churches, et cetera, that makes perfect sense. As you deal with those episodic events that those types of environments can support and help to close the health gap, you still have patients who are dealing with chronic diseases that require management and care. So technologies like remote patient monitoring and virtual care, telehealth, are now really important as well too. Can you share some of your thoughts around how do we continue to expand the adoption of these types of technologies within the rural community? And then more importantly, how do you get patients to continue to adhere to their health plans or the plans that their doctors have outlined to treat them with those chronic diseases as well? Are you looking at things like, for example, gamification or cognitive neuroscience technologies? Just curious from your perspective as you work with these entrepreneurs and healthcare professionals, how are you guys approaching that?
Yeah, I think this is something that goes well beyond rural healthcare.
Right.
Most of us in the United States, even myself alone, the only time we actually get motivated to engage in our health for most of us are when we're sick, right? And so kind of changing behaviors around being more preventative about our health, going out to exercise, lose weight. We all know we need to do that, but getting that extra motivator doesn't typically happen until you're sick, right? So people that kind of hear me about remote patient monitoring, I'm not sure that that's the right data to change behaviors. And I see the opportunities with the technology of collecting biometrics on a continuous basis, but I would argue that we need to know more from the patient's own voice of how they're doing, and we need to monitor that continuously over time. And so I'm a huge fan of patient report outcomes and using even computer adaptive testing to collect psychometric instruments pretty efficiently using item response theory and doing it in broad domains around how do people perceive their emotional levels to be? How do people perceive their physical functioning to be? How do people perceive their social functioning to be? And if I can understand that, that is how I can drive behaviors to get people to potentially prevent chronic disease and promote health. And I'm not sure that knowing what my heart rate variability is or seeing my blood pressure trend over time is going to be that driver for me to do that.
Absolutely.
And so we're really focused on how do we better collect PROs out in these communities at the right time so we can understand where are our patients at from their own perspective in engaging in healthcare.
Makes perfect sense. And I knew the time was going to fly quickly. I have so many more questions I want to ask you, so I will have you back on the program. But I did want to give you a few minutes of time as we wrap up this session to talk about the work that you're doing in the Innovation Center.
Oh, this is the most fun that I have in my job. And one of the things that we're really lucky at Rochester is our health system is fully integrated into our parent university. And so that gives me the unique opportunity to put under the same roof faculty from the engineering school, the data science institute, computer science, school of music. Business school with side by side with clinicians from our medical school, dental school, and nursing school. And this group is just tasked to kind of think about the frontier technologies that are going to be 5 years out, 10 years out in healthcare. So a lot of the work we're doing in that space is in the VR space, AR space. We're an optics town, being home of Kodak. So we have expertise in that space. So we're doing a lot of development there. We're interested in ultrasound and in point of care ultrasound and wrapping that with machine learning and artificial intelligence and how can we make those sensors better. That is a space that we're developing a lot. And then you hinted on Chat GPT-4. I pretty much told my whole innovation team, I want you guys playing with it. I want to know what its limitations are. Where does it hallucinate? Where is it more precise?
Exactly.
My clinicians thinking about what types of problems can we apply this to. So those are areas that excites us on innovation.
Well, that's great. It sounds like you're doing some amazing things to disrupt what's happening in the marketplace, and I applaud you for that. And I applaud you, more importantly, for your commitment to rural health. I grew up in a rural community. I understand the limitations. I remember my mom's cardiologist coming to town once a month because he made the rounds around the community, didn't live in the community. And so the fact that there's lack of these types of specialists in those communities have a huge impact on their overall care for. So anything we can do to continue to close those gaps, I commend, I support, and I applaud you and your organization for its efforts. So thank you again for taking time out of your very busy schedule here at the conference to stop and chat with me. And as I said before, I am going to definitely have you back on, and we can continue a deeper dive into this and many other discussions going forward. Thank you again, Dr. Michael Hasselberg, for your commitment, your time, your effort. And I look forward to seeing you on another episode.
Love it. Thank you, Chris. I look forward to continuing the discussion.
Wonderful. Well, that's a wrap. Again, thank you, listeners, for taking time out of your busy schedules to listen to Straight Outta Health IT. As I say on all of my programs, let's make this episode go viral. And I appreciate your support. Your feedback and comments are always welcome. Take care, and God bless.
Thank you so much for listening to Straight Outta Health IT. We hope you enjoyed today's guest. For more unfiltered dialogue of healthcare leaders and influencers, be sure to tune in next week. For the show notes, transcripts, and resources, please visit Apple Podcasts, Spotify, or your favorite streaming platform. We invite you to give us feedback by reaching out to Christopher Cunny on LinkedIn, just searching for Straight Outta Health IT, and you'll find us. We are constantly having live discussions about diverse topics in the industry.